Hi, everybody. So today's discussion is exploring pain and pain relief in cancer patients with Dr. Christian Archer. The description is this educational presentation offers an in-depth look at the complex nature of pain in cancer care. Dr. Archer will introduce the fundamentals of how pain is generated and processed in the body, helping to build a clearer understanding of pain signaling and its clinical implications. This session will also explore a range of evidence-based strategies for managing cancer-related pain, including pharmacological treatments, non-pharmacological therapies, and integrative approaches that address the whole person. In addition, Dr. Archer will discuss an often under-recognized issue, the persistence of pain after cancer treatment, highlighting the challenges faced by survivors and considerations for long-term care. This talk aims to provide practical knowledge and a broader perspective on improving quality of life through effective pain management. So, thank you so much for joining us. I am going to hand the floor over to you. Thanks.
Thank you. Give me just a moment to share my screen. Fabulous. All right. So, like I mentioned, I'm hoping that this talk can be as interactive as you all would like it to be. So, if there are questions that come up during or after, I'm happy to get to those. I tried to leave a good bit of time for questions because this is a really big topic. And so I'm going to kind of give a broad overview and happy to go into more into detail into whatever folks would like. And so, what I'm hoping to talk about, starting out with a definition of pain, which is maybe a bit trickier than you might think, talk about some standard treatments, some integrative and alternative approaches, and then some time for Q&A. So, first, when we talk about defining pain, I would love for you all to take about 30 seconds and just think about what pain means for you, whether you have experienced some kind of pain or are experiencing some kind of pain, if you've seen pain in a family member or loved one, what, how do you know that you're feeling pain? Is there a certain kind of sensation in your body? Are there certain thoughts that come along with those sensations when you're experiencing them that let you know that I'm feeling pain? And if you'd like, you're welcome to type something in the chat that goes along with what your definition of pain is, or you can just kind of keep it to yourself. But I just wanted to pause and start there and really acknowledge that pain is very multifactorial. There are a lot of things that contribute to it, and everyone's definition, experience, and understanding of pain is different as well. If we wanted to take a look at a Western medical definition of pain, there's a organization of clinicians and health providers that come together to talk about pain every year, the IASP. And in 2020, they settled on a definition that says an unpleasant sensory and emotional experience that's associated with or resembling that associated with actual or potential tissue damage. So that's a rather convoluted sentence, but I think a few parts of it to highlight are that there's a sensory experience to pain. There's what you feel. There's also an emotional experience to pain, or in other words, there are non-physical components to pain that I'm going to talk about because I think it's important to mention and acknowledge that there are physical sensations, things that we feel in our body, and then there are ways that we respond to those sensations. And all of those things are bundled up into what we talk about as pain. And another point to mention in this definition is that it says that they're associated with or resembling things that are associated with tissue damage. So, in order for someone to experience pain, we don't necessarily need to be able to point to something on an imaging study or on tissue sample and say, this is what's happening, therefore you're experiencing pain. Pain is a fully subjective experience, and there's no
It's
way there's no way for us to measure it outside of just talking to someone about their lived experience. And that's what makes pain really challenging when we think about how do we measure it, how do we assess if someone's pain is improving, and makes things a little bit challenging. The next thing that I would want to talk about with you all is that there are three kind of very rough categories for pain. Um, the first is nociceptive pain, and that's pain that's caused by actual or threatened damage to tissues, damage to parts of our body. There's neuropathic pain, and that's pain that is caused by damage to the nervous system, damage to the nerves that send and receive pain signals. And then there's kind of a newer third category that's called nociplastic pain. And essentially, it is pain that's arising from altered nociceptive function without evidence of tissue damage or neuropathy. What does that mean? It essentially means that someone is experiencing pain, but we don't necessarily have a sense of specific tissue damage or nerve damage that goes along with that pain. And the leading thinking now around this kind of nociplastic pain is that it's related to the way that pain signals are moving around in our brain and in our mind that is contributing to the kind of pain that folks experience that doesn't necessarily have a specific tissue or nerve problem that we can point to. Who treats pain is the next really good question. Well, palliative medicine, that's the work that I do. I'm a hospice and palliative medicine physician, especially for folks who have cancer and other serious illnesses. Palliative medicine is one of the main teams that's involved in managing pain, but there are a slew of other folks that can and do often get involved to help folks with pain. There's anesthesia, pain specialists. There's a field called physical medicine and rehabilitation. There's interventional radiologists, radiation oncologists, physical and occupational therapists, pain psychologists, and then a variety of alternative and integrative practitioners, chiropractors, acupuncturists, energy workers. The list really goes on and on. And so there are a variety of folks that kind of bring different expertise to bear on pain. And I just thought it would be worth taking a minute to talk about the different perspectives that some of the common people who treat pain have. And so anesthesia pain medicine is a group of folks that tend to emphasize intervention and management of pain around the time when people are being operated on, people are having surgeries. Usually this is more acute, and usually the focus that they have is on what's causing pain, what's the mechanism, what's the pathophysiology that's making this pain happen, and what are we going to do about it? Usually with some kind of intervention like an injection or an implanted device or a procedure on a spinous process in order to alleviate pain. Another approach would be, or perspective would be that of physical medicine and rehabilitation. And they're a group that frame pain through the lens of someone's function and disability. So how is pain, the experience that you're having of discomfort, limiting your ability to move around, limiting your ability to do things that you want to be doing? Usually they manage pain that's more chronic, and they're a very multidisciplinary group, often working with physical therapists and occupational therapists and other individuals to help support and restore function. For example, after an individual has a stroke or a spinal cord injury or something of that nature, that's generally when those kinds of teams get involved. And then there's palliative medicine. And I have a bias clearly as being a part of this profession, but total pain is something that's been pioneered as a way to conceptualize pain by hospice and palliative medicine. And the founder of hospice and palliative medicine, a nurse from the UK named Cicely Saunders, proposed this idea that physical pain is just one of the many contributors to a person's felt experience of pain and suffering. So in addition to the physical things that are going on with their body, there's spiritual and existential pain that comes particularly when folks are facing their mortality, facing a diagnosis that may potentially limit their life in some way. There's social pain and the stress that comes with the way that your body changes, the way that your illness is affecting your ability to engage with your loved ones, your ability to be the person who you've seen yourself as in the world, whether that's the work that you do, whether that's the role that you play in the lives of those around you. And that can contribute to pain. And then there's psychological pain. So kind of what I was referencing earlier, but the way that pain signals travel into the brain and interact with our thoughts, feelings, and emotions also changes the way that we feel and experience pain. And I'll talk about some of the research in a few minutes that shares some more details there. But this conceptualization, this framework for pain is really being more expansive than just what you're physically feeling, I think is very helpful to get across and something that I wanted to spend a few moments on. Diving into the non-physical contributions to pain, there's actually really robust literature at this point. There's been kind of big analysis of 185 studies, over 500,000 participants, and they were looking at what are things that are associated with folks who develop serious pain, who develop chronic pain. And two of the strongest signals that they got were that folks who have poor social networks, poor social supports, people who are of a lower socioeconomic status are far more likely to experience intense and chronic pain than their counterparts. There's also been another analysis of over 1,000 studies that looked at more predictors of things that predict the development of chronic pain. And two of the strongest signals that they got were depression, mental health disorder, and fear avoidance, which is essentially fear of pain, making individuals change the way that they work, the way that they live, the way that they move their bodies. Folks who are more likely to do that, to respond to pain with fear and avoidance, are more likely to develop chronic pain. And this is not to say that, or rather, the goal of having this slide here is, again, just to note that there are a wide variety of other things. That total pain picture is really going into your mental health, going into your social environment and supports, that all of those things have been proven, really beyond a doubt, to be contributing to the pain that folks experience and how they live with it and move through it. So takeaway number one from this presentation is what's happening to your physical body is definitely and undeniably a part of your pain, but it's not the whole story. Now, I want to go into talking about some of the standard and typical treatments that we have for pain, and there are a wide variety of them. But before that, I'd want to just pause and see if folks have any questions that have come up, any things that are worth clarifying right now.
Someone did write in the chat, Victoria shared, it can be hard to determine when discomfort should be determined to be pain. I've never taken pain medicine for my neuropathy, but I do experience a lot of discomfort on a scale of 1 to 10, maybe a 5.
That's a really great point. I appreciate you bringing that into the space, Victoria. A couple of things that I would want to comment on just from that are that the language is challenging. What someone calls pain, what someone calls discomfort, what someone calls just a feeling or sensation, all of those things one person's discomfort might be another person's pain. We use the pain scale really often. I talk to patients about it, and I was talking to a patient just today who said that for him, his pain is a 10, and when it's a 7, it's manageable. It feels like it's reasonable. For someone else, a 7 might still very well be unbearable, difficult to tolerate, and they would want the pain score to be a little bit lower. Where I go to often in these kinds of cases where I'm having trouble getting a sense of what someone's experiencing is to talk to them about how it's impacting their life. Because of the pain that you're having or because of the sensation that you're experiencing, is it more difficult for you to do things? Are there things that you're not doing, like walking around, like getting together with loved ones, friends, and family because of that sensation? Are there limitations on your life, on your ability to function in the world in the way that you previously did? And that can often help me when I'm working with folks to decide, is this significant enough that we should try to do something about it? And what do we do about it? We go into some of the kind of more standard treatments. First and foremost, what I would say in this room is that usually cancer-directed treatment is something that will improve pain if we think that the cancer is causing the pain. This is very individualized. I've had some folks who feel like their pain improves right after the first treatment. Sometimes it takes a few treatments. Sometimes folks will, unfortunately, have side effects from treatment that may cause more pain than what they were experiencing before, whether it's nerve pain and neuropathy, mucositis, or difficulty in the mouth that's related to certain treatments, or myalgias and arthralgias, which are just fancy words for muscle aches and joint aches. All of those things can sometimes come from cancer treatment. So it's kind of a double-edged sword. There are times where the things that we're doing to help with the cancer will help pain. Sometimes, unfortunately, they cause pain and discomfort as well that we then need to deal with and manage. When I think about approaching cancer pain, the first things that I start with are non-medicinal topical treatments. Are there certain movements that you can avoid that are causing pain? Are there things that you're doing, certain activities that bring about pain that you can have someone else do, a family member or a loved one or a friend? Are there changes in your position, changes in your bedding, changes in your chair, changes in your activities that you can modify? Heating pads, ice packs, all of those things can be helpful. Some folks find it helpful in the evening time to lay on a heating pad. And if that works for you, or if taking a hot bath works for you, that's amazing. And I would encourage you to do that. Then there are some topical treatments, the more common ones like icy hot
Got
and
it.
Bengay.
Mm.
Was there a question there? Maybe not. Um, Things like lidocaine patches and diclofenac gel have medication in them that can be applied either in a cream or in a patch over the body to provide pain relief to specific regions. The reasons why I like these medications is that they're very safe and they have minimal side effects. And that's something that I'm always thinking about when I'm talking to my patients about pain and pain treatment. What are the benefits that we're going to get, and what are the risks or the side effects? Speaking of kind of the oral treatment with minimal side effects is acetaminophen or Tylenol. It's by far the safest pain medication. Excuse me. In my experience with patients, it's kind of 50-50. I have some folks who swear by it and feel like it helps them a great deal. I have some folks who feel like it really helps very little with their pain, but it's something that's worth trying because it's quite safe when taken in the right doses. Then there are stronger non-opioid pain medications, things you may have heard of like ibuprofen or Motrin, naproxen or Aleve. Those are all NSAIDs or non-steroidal anti-inflammatory drugs that you can pick up over the counter. They carry more side effects. I would recommend talking to a physician about them because they can sometimes affect the kidneys. They can sometimes affect other parts of the body. There are also a class of medications, things like gabapentin, pregabalin, and duloxetine that are being used more often for a variety of different types of pain, usually more if we think that there might be a component of pain from the nerves. And then opioid pain medications are the next thing to talk about. Excuse me. And I describe it as Pandora's box because there are a wide variety of different medications from morphine and hydromorphone to fentanyl, buprenorphine, and methadone. There are a variety of different routes of administration, tablets, pouches, liquids, films, and IV. The effects can vary in duration, and the doses can vary quite a bit too. Some of them are measured in smallest micrograms, some are delivered in milligrams, all of them with different effectiveness based on the dosing. There is excellent evidence for opioids in cancer-related pain. ASCO, which is the American Society of Clinical Oncology, says opioids should be offered to patients with moderate to severe pain related to cancer or active cancer treatment, unless there's a contraindication. Cochrane, which is a research review organization, says that while the amount and quality of evidence around the use of opioids is disappointingly low, the evidence that we have indicates that around 19 out of 20 people with moderate severe pain who are given opioids and can tolerate them should have that pain reduced to mild or no pain within 14 days. So 19 out of 20 people, 95% of people started on opioids for cancer-related pain will have that pain improved dramatically within 2 weeks. On the other hand, the reason that I mention them lower down on my hierarchy of medications when I'm thinking about providing pain medicine to a patient is that they have a tremendous amount of side effects that need to be taken into account. In the short term, they can cause things like sleepiness, constipation, nausea, vomiting, itching, urinary retention, and respiratory depression when given in too high doses. In the long term, there can also be side effects like trouble with sleep, disordered breathing, physiological dependence and addiction, changes to hormone levels in the body and changes to the immune system, hyperalgesia, which is when the pain medicines, when folks are taking them for long times, actually cause worsening of pain. and complex dependency, which is where someone who's been on medications for pain like opioids for long periods of time can find it quite challenging to come off of the medicine, even if they're not taking it in ways that are not prescribed by the physician. There's a dependence relationship that develops in relation to the person's body, their mind, and the way that the medications are changing their body's receptors, their body's pain receptors. A word on chronic survivorship pain and opioids. This is much trickier. ASCO says that although opioids are the foundation of cancer pain management and moderate to severe acute pain, as well as pain caused by advanced disease, the efficacy of long-term use in survivors has not been well established. In chronic pain that doesn't come from cancer, the evidence is very limited. And there's actually some evidence that at 6 months out from treatment, folks with opioids report that the medications have reduced effectiveness. They don't report improvements in their functionality and functional status, and they report persistent pain. And so this is an area of really active work and research for myself and hospice and palliative medicine clinicians and oncologists to try to figure out how do we help folks who have persistent pain either in relation to their cancer or as a side effect or sequela from cancer treatment. And this is like I said, a really active place of research because the current therapies that we have don't have very good evidence for the long term. This is also a slide that I put up just to show that in folks who are receiving treatment for cancer, there are a wide variety of chronic pain syndromes that can develop. And I'm not going to read all of these, but there are just a tremendous variety of conditions that can develop as a result of cancer treatment, things that myself and oncologists need to figure out ways to manage, from some simple things like those arthralgias and joint pains to vertebral compression fractures related to cancer being in the bones, the ways that radiation can cause persistent pain after treatment. There are some things on this side around results of stem cell transplants that some patients receive, and just pain syndromes after surgery, like lymphedema, which is something that's unfortunately very common and very challenging to manage. In order to help with the work that we do, there are other specialties that we may consult. Anesthesia pain or interventional radiology is a group that we might ask, is there a procedure that might help with pain, either blocking some nerve signalings or helping improve and support a person's spine with something like a kyphoplasty. Physical therapy and occupational therapy are very often things that I lean on. Would an exercise program help someone's mobility to improve their pain, or reduce the swelling from lymphedema to improve their pain? Radiation oncology is another group I very often work in coordination with. And the question for them is, would a focused beam of radiation to a particular area of cancer, often areas that are bony, for instance, tend to respond very well and have patients report improvements in their pain. So these are kind of the most common groups of folks that I work with when I'm managing pain in the setting of cancer. So takeaway number 2 is that there are a variety of different tools, standard tools to treat cancer pain, and each of them really have their own benefits and risks that need to be weighed. And that's a big part of what I see my job as, kind of judiciously thinking about how we use these medications to best help people and minimize harm. Now, I want to take a pause, 1, to catch my breath, and 2, to see if there's anything popping up in the chat.
Sorry, I was muted. So there is a person commented, they said, how do you advise patients to talk to their doctors about getting pain meds? Whenever I ask doctors and or oncologists about pain meds, they treat me like I'm an addict and tell me I don't need them, that I tried Tylenol. I had a breast implant removed while I was awake, and I asked for pain meds, and they gave me 4-oxy with a pamphlet about addiction. So that's one question, and then there's one other. So I don't know if you want to answer that one first.
Awesome. Yeah, I think that what this person has raised is a really real and valid concern, and things that come up not infrequently. My recommendation would be probably to see if you can ask to be seen by palliative care. One of the things that often comes up is that oncology teams have lots of patients to see and very limited time to see folks. And so they're not able to do the kind of thorough assessment of a patient's pain that my team is, to kind of come to a sense of what's going on, what's causing this pain, and what might be most helpful. As I mentioned before, the opioid pain medicines in particular have good effectiveness for certain kinds of pain and also lots of side effects. And so giving the medical team that you're talking about the benefit of the doubt, I wonder if they are trying to be judicious with their use of these medicines to make sure that they don't cause more harm than good. But it sounds like a situation that probably should have more conversation. And if the team that you're working with is not able to, it may be worth considering if another kind of pain specialist might be able to get involved. Someone from my team potentially, or from some of the other teams that I mentioned, like anesthesia pain, for example.
Mm. And then there's one other question from Joan. She said, "Hi, thank you for your wonderful presentation. Why isn't LDN mentioned as a way of managing pain? Thanks."
Hi, a good question. I am assuming that you're meaning low-dose naltrexone with that LDN, although feel free to correct me if I'm wrong. And the reason that it's not mentioned here is purely out of a sense of ignorance on my part. It's a relatively new therapy that, in my experience, does not have a ton of literature around it. It's something that I'm actually actively learning about and working to implement into my practice right now. And so I would say that the reason that it's not on here is because it's a place of growth for me in terms of learning who are the best patients to receive that kind of therapy. I have had some of my colleagues report really good effectiveness with some individuals who have done it. There's a foundation called LDN Research. Thank you. Thank you, Joan, for passing that along. I'll definitely take a look. Maybe we can talk more at the end.
Sure.
Any other questions right now at this spot? Okay. Doesn't seem that way.
All right, so now we're going to move into talking about some integrative and alternative approaches to managing pain. This is something that I get questions about not infrequently, and so I thought it would be worth spending a few minutes talking about this. What else can help with your pain outside of some of the standard treatments and standard therapies that I've discussed? First, I would really just invite a word of caution and just say that there are a lot of treatments that are marketed specifically towards cancer patients to treat the cancer, to help with pain, and that there is kind of an industry around cancer and cancer pain and folks that target therapies towards these individuals. And the questions that I encourage my patients to ask: first, is this safe? And I would encourage you to talk with your doctors, to talk with your medical team about therapies that you're thinking about, things that you've heard about, so that we can help you try to get a sense of, number one, is this something that's going to hurt you or not? I always see my job as to first do no harm. And that's the first thing I think about with all of these kinds of therapies. The second question is there evidence? And that's worth maybe talking to your doctor about as well. And I'll share some resources at the end of this for some good places to go to potentially look and see if there's research or what the medical literature says about any particular intervention that you're thinking about, to see if there's some evidence of benefit from the way that we study and look at these kinds of therapies and treatments. Third, I would always ask my patients to consider, is this expensive? And to think about the cost or the price tag for some of these interventions as something to weigh in addition to the potential side effects, the evidence of benefit, and really just include that in your assessment of, is this something that you would want to pursue? Because unfortunately, a lot of the therapies that I'm going to discuss are often not covered by typical insurance and require folks to pay out of pocket, which for some of these therapies is really terrible because they have some good effectiveness to them. And so what I'm sharing here is also from the ASCO cancer group. And these are some treatments that they have put together, some integrative treatments for patients with cancer who are experiencing pain. And these are treatments that have some better evidence base. And I'm kind of circling the ones up here as kind of the most common kinds of pain and some of the therapies that have the best evidence. So the ones in light blue and dark blue having a more robust medical evidence base than others. And so I thought I'd take just a minute to talk about some of these therapies. Acupuncture is something that I'm sure many folks have heard about before, but it's a key component of traditional Chinese medicine, which is an entire philosophy and school of medicine. And acupuncture is a technique within that school that involves inserting thin, sterile needles into specific points on the body, acupoints that are thought to help the body balance energy flow and promote natural healing. In cancer populations, there have been 3 large collections of studies over the past 15 years, and 2 reported improvements in pain. One reported that there wasn't quite enough evidence for cancer-related pain. But from my perspective, I think that this is something that can be quite helpful for individuals for a variety of different pain conditions. Reflexology and massage was something else that was mentioned there. Reflexology is a complementary therapy that involves applying pressure to specific points on the feet that are thought to correspond to different organs, glands, and systems in the body. And then traditionally, this reflexology is often given by massage therapists. And so I've kind of put them into one. And there's at least 13 different research studies that document improvements in pain in cancer populations in general. And what I would say at this point for me is that both of these therapies do have some decent evidence base for benefit. And importantly for me, they have minimal side effects and minimal risks and harms to them. And so these are therapies that I will often talk to my patients about just because of that balance of risks and benefits. Now, I would like to spend another minute or two just talking about psychological therapies. And there are a variety of these. There are traditional therapies like CBT. There are mindfulness-based therapies like acceptance and commitment therapy, mindfulness-based stress reduction. All have shown some efficacy for pain and other psychological symptoms or psychological components of pain. Then there are some newer therapies that are being developed that are really kind of on the cusp or the leading edge of pain management, and those are pain reprocessing therapy and emotional awareness and expression therapy. Both of these therapies, where they differ from CBT, mindfulness-based programs, they aim to directly reduce or eliminate pain by targeting its central nervous system origins. So if you remember earlier on in the talk, I was talking about the 3 kinds of pain and how there's kind of a third kind of pain, that nociplastic pain that we think is less related to tissue damage, less related to nerve damage, and more related to the brain's circuitry and the relationship between the brain and the mind. These therapies act on that. So pain reprocessing therapy targets this kind of pain by shifting patients' beliefs about the causes and threat value of pain. It presents pain as a reversible, brain-generated phenomenon, not indicative of peripheral pathology, consistent with active inference and constructionist accounts of interoceptive and pain. And then the emotional awareness and expression therapy posits that unresolved emotional experiences, a wide range of them, alter brain pathways involved in both pain and emotional processing, leading to or exacerbating chronic pain. The reason that I bring them up here is, again, just to note that with my conceptualization of pain as being beyond just the physical, I think it's important to acknowledge the different ways that groups are trying to work at some of those other components of pain. And this is not to say that there is almost certainly a physical component to pain for individuals who have cancer, but just to note that there are other things that may be going on and other ways that you may help alleviate some of your pain by engaging in some of these other therapies. I thought it worth talking about medical cannabis, something else that I get asked about not infrequently. There were a number of older studies, maybe 10, 15 years ago, that were more optimistic and favorable. Newer studies and analyses of kind of the wide range of data that we have kind of tempered those results. The Cancer Society guidelines state that evidence remains insufficient to recommend for or against cannabis for cancer pain. There are also many differing treatments at different doses. There's a variety of products, routes of administration, ways that people use it. All of these things, I think, make it very difficult for us to study cannabis adequately. And so the way I talk to about my patient, the way I talk to my patients about it is that it's something that may be worth a shot, particularly if we've tried a few other interventions and we're still having trouble managing pain. But I can't make a really strong recommendation for it. And in my clinical experience, I've kind of seen that bear out that I have a portion of patients who find that these kinds of cannabis therapies are helpful for pain, and a portion of patients who really find that either they're not helpful or the side effects that they experience from them are not desirable, and so they don't use these medicines. What I'd like to talk about next, and kind of bringing the talk to the close, is some resources that I mentioned for researching integrative therapies. So the National Center for Complementary and Integrative Health is kind of a subset of the National Institutes of Health, and they have a website that you can go to along with Memorial Sloan Kettering, actually, and Memorial Sloan Kettering's website is directed at cancer therapies and integrative medicine specifically. And so those are two good resources that I will encourage folks to take a look at if you are thinking about any kind of integrative therapy, any kind of supplement. You should or may be able to find some information on these websites. There are obviously a wide range of different supplements and different therapies that are available, but this could be a first place to look if you're hoping to gather some more information in addition to talking to your doctors and talking to your medical team. So, kind of bringing us to a close with hopefully some time for questions and some conversation towards the end. Pain is as complicated as human beings are. There are a variety of different approaches that I've shared with you to thinking about pain and ways of treating pain. I don't think that there's one best approach, but the approach that I try to take is to address different aspects of total pain, different aspects of those components from physical to psychological to social, in order to help my patients, I think, get a little further than relying on just one treatment alone or one type of therapy directed at uh, managing pain in one way. I hope that I've shared with you guys some of the different integrative and alternative approaches to pain. There are a variety of them. Some have good scientific evidence, others less so. And I would just invite you to tread cautiously and always involve your medical team when you're thinking about new therapies or medications. And yeah, maybe I will stop there. And I hope to leave some time so that we could have some questions and discussion if there are specific things that folks are hoping to talk about. This is a really broad area of medicine, and I definitely couldn't cover it all, but happy to chat with you all if there are things that are coming up or things that'd be helpful to talk about.